So, welcome everyone to the Moorfields UCL Glaucoma webinar, which for the first time today is jointly hosted with our friends from Columbia University. So thanks very much to all of you for joining us. So the panel discussions will now be joint with Moorfields and Columbia. And our keynote lecturer today in two parts is Don Hood, who's the James Bender Professor of Psychology and of Ophthalmic Science at Columbia. Don's been faculty at Columbia since 1969 and has won all three of its major teaching awards. Most recently, one of Don's leadership positions is as editor-in-chief of our very important journal IOVS, and we're grateful for him for taking on that role. From my point of view, Don's work really had quite a profound impact on the way I care for my glaucoma patients a few years ago. When following one of his talks and actually one of Jeff's talks, I really wasn't focusing on the macula and on the 10-2 when assessing whether some people had glaucoma. And at that point, I was quite worried how much glaucoma I'd missed in the past. And I think I've picked up quite a few extra important cases moving forward since then. And so I think the webinar today is on a really, really important topic and should generate some good discussion. So Don, thanks very much for being with us. And let's commence with part one of your presentation. We're going to do this in two parts. So that we can have a panel discussion in between. And your screen looks great. So if I could remind all other panelists, can you please go on mute, and so we can just focus on hearing Don. Thank you.
Okay, well, first of all, Anthony, thank you very much for inviting me and my colleagues at Columbia. I want to thank both you and Gus for inviting me to give this talk. Let me just start with the obligatory financial disclosures. I have both grants and equipment from Topcon and Heidelberg, and these are definitely relevant, as you'll see, to this discussion. So I've been asked to talk about diagnosing glaucoma, reasons for rethinking some common clinical practices. And the basis for this goes back to two short perspectives that Gus and I wrote about over 2 years ago at this point. And you can see that work, of course, was based upon lots of work that we did with our colleagues, and some of that work can be found in this. Can you see my cursor, by the way? Yes. Okay. In these review articles. So.
Sorry. Yes, we can see your cursor. Sorry.
Okay, good. In these perspectives, we defined what we call the common clinical paradigm of tests. And what we meant by that was at least 2015 or so, or 2012, when we started our work, in addition to a disc exam, whether it's a fundus photo or just an exam, there were two primary tests being done. The 24 or 30-2 visual fields and the OCT disc scans. So these tests represented what we call common tests in the clinic or common paradigms. The common paradigm also included an analysis of metrics. So if you wanted to compare visual fields to OCT, it was not uncommon to look at summary statistics or metrics, we call them, like pattern standard deviation in terms of the visual fields, and global or quadrant thickness in terms of the OCT. Then the fourth aspect of the common clinical paradigm is many glaucoma specialists were not looking at the actual images themselves. And so what we did in these two papers is we suggested 4 changes to this common clinical paradigm. And to be honest, some of that was based on published evidence, but some of it was based on unpublished evidence, and some of it was based on our qualitative observations. And so what I want to do today is, first of all, review these 4 recommendations and bring you up to date with evidence that we now have to further support those recommendations. And then in the second part of the talk, or the second talk, I'll talk about where you can find reports on your machine that we think the clinician should be looking at, and then a little bit about what's new and what's coming next in terms of how these reports are going to be changing. So let's start with the first recommendation. So the first recommendation we've been making for a number of years is we argue that if there's a good reason to do a visual field, there's probably a good reason to do a 10-2 as well, whether it's the first visit or the second visit. And the reason for that is, well, there are two reasons. One is macular damage is very common, even in early glaucoma, and it can be missed or at least underestimated with the 24-2. So I'm going to review the evidence for that. But first, let me talk about why it's occurring, just to motivate this. So this goes back to a paper in 2011 where we looked at these arcuate defects. And I'm going to summarize it, the anatomy here, using this plot here. And what that is that's the loss of OCT ganglion cells as seen in early to moderate glaucoma. It's the average of a whole bunch of eyes, right? And so what you'll notice, that's plus or minus 8 degrees. That's what I mean by macular. And what you'll notice is that most of the damage is down here, right? And we now know that the reason for that is, in general, in most eyes, these ganglion cells send their axons right where you would expect. They go into the temporal quadrant, which is less vulnerable than the other quadrants to glaucoma damage, right? But these ganglion cells here send their axons right smack into the most vulnerable region of the disc, what we call the inferior vulnerability zone. I think, Ted, it's your inferior arcuate region, pretty much the same regions. And so that's more vulnerable, and that's our macular vulnerability zone. And here's what it looks like on a fundus view. All right, so there are two reasons really that we now realize for macular damage. The primary reason for these local defects is the macular vulnerability zone, but there's also evidence for a overall or diffuse damage that can occur to the macula as well as outside the macula early in the disease process. And here are some recent papers that confirm the macular vulnerability zone. There are a couple of papers from Korea, from Keogh Parks and colleagues, and then there's a paper a couple of years ago from the San Diego. All right, so macular damage is very common. In this perspective here, we went back and looked at data we had published with our colleagues at Columbia a couple of years earlier. And long story short, we found that based on the OCT, the macula was affected in about 88% of these eyes. And these eyes were confirmed glaucoma, but early, meaning the mean deviation was better than -6 on the 24-2. And about 3/4 of them had damage in the macular vulnerability zone. That there now is more evidence for this. The papers in yellow here are from our group. The ones in white are from other groups. All right, the second point is macular damage can be underestimated and even missed with 24-2. So also using data that we had already published, we pointed out that the standard, like Oates criteria, pattern standard deviation or glaucoma hemifield test, that will miss eyes with early but confirmed glaucoma. And again, in this case, there are studies that predate what we did that were largely ignored, and then a number of studies since. Okay, so this illustrates the reason for this problem. So if you look over here, you've got visual fields obtained on the same day from the same patient. You can see this looks pretty good, but there's a deep defect here. And the reason why it's missed here is because it falls between the test points. Well, if you look over here, here's our early to moderate loss of ganglion cells, heavy in this region here, but overall in this region. And you can see it's falling inside the 24-2, which are morphed to take into consideration that the ganglion cells are displaced. And then compare that to the 10-2 that does a good job of sampling that region. Okay, so the second point we made is that in addition to this report and scan of the disc, it's really important to routinely get a scan of the macula and look at the probability maps. So I'm going to do two things at once here. This is an important slide to pay attention to. Not that the others aren't important, of course. And so one thing I'm going to do is I'm going to make sure we all have the same meaning of probability map, but I also want to illustrate the report that we proposed in 2014. So this is based on two cube scans, a cube scan centered on the disc and a cube scan centered on the fovea. These particular cube scans were done with a Topcon machine, but it's effectively the same thing you get from your cirrus if you're doing both fovea and disc scans. That's one of the B scans, and from this cube scan, we get retinal nerve fiber layer thickness, where red is thick and blue is thin. And from the macula, we get retinal nerve fiber layer thickness and ganglion cell plus interplexiform layer, which I'm going to just call ganglion cell, thick, thin. Right? These get turned into probability maps by comparing them point by point to the thickness map. And this is pretty much done on all your machines. They all have something similar to this. Now red is bad and green is good. So this is in our hands, it's a continuous scale where dark red is significant at the 0.1% level, yellow would be 5%, green is better than 10%. So that's the probability map. For our purposes, we flip it across along the horizontal meridian so that we can then put it over here because we're going to compare this in a little bit to visual field. Now you want probability maps of both ganglion cells and retinal nerve fiber layer. They will often give you different information. So we also turn the retinal nerve fiber layer thickness plots into probability plots, stitch them together, put them in field view. And again, significant, not significant. So that's the probability map of the retinal nerve fiber layer. That's the probability map of the retinal ganglion cell layer, and they're both in field view. Okay, so here's an illustration of why you want the macula ganglion cell map. This looks pretty good here. That looks pretty good here, right? I think most of you would agree. This is the thickness map. You can see there's a chunk out of this right here. That actually is what's causing this little dip, believe it or not. And this is often easier to see on a probability map. Here's the probability map in field in the retina view. So this is the abnormal region that's associated with this, that's associated with that. If you have a real keen eye and you're used to looking at images, if you blow this up, there's the defect. You can often see these defects if you bother to look at the B-scan circle scan. Okay, point number 3, don't use metrics for the following reason, for the following purpose. So the purpose here we're going to talk about is structure function comparisons. And as you know, the reason for this is that you have no litmus test for glaucoma, and it's usually characterized or defined as a particular pattern, in particular arcuates, both on visual field, that's the functional, and some structural measure. For our purposes, we'll talk about OCT, right? So what we argued is don't use metrics for this purpose. That's why I put the lines through all these, right? And the reason for this is visual field metrics, mean deviation, pattern standard deviation, glaucoma hemifield test, can miss glaucoma misdamage. And here are some references. Likewise, the OCT metrics, such as global or quadrant retinal nerve fiber layer thickness, can miss damage. In fact, we've got some recent data that's under review that suggests it's even worse than we thought. All right? Here's a paper we published recently, and I won't go into the detail, but these are a different group of patients. These are prospective patients that Gus and colleagues have been collecting at Columbia, and we took 53 that were characterized as definite glaucoma, but early, and a large percentage of them would have been missed by these standard metrics. So don't use metrics. So if you don't use metrics, what do you do? Well, we've been arguing for years you want to topographically compare the abnormal regions here to the abnormal regions here. And let me illustrate that with our report. So the report makes this easy to do this comparison, because what we've done is we've added the 24-2 locations here and the 10-2 locations here. In some versions of this, the 10-2 locations are also in there. So what this means now is if this, here's the visual field for this patient. By the way, make believe these points aren't filled because that takes a separate effort. But make believe that they're just small dots here. So what you can do is you can circle this and circle that. You can do that either in your head or you can do that physically if you have a report. And you can see that this is probably related to an ocular defect. But notice the 24-2 missed this here, missed macular damage. It's everywhere. Macular damage, macular damage, macular damage. If you do a 10-2, right, again, we circle the points, right, you can see the agreement. So that's what we mean by topographical agreement. And now you might notice that this assumes that one can do this, that one can, that one can expect good agreement and that one can then somehow make that comparison. And at the time we proposed this, we got a certain amount of grief about, oh, well, don't you know structure comes before function and blah, 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 and it's qualitative. So we spent a fair amount of time, and we in this case is Manos, who's a postdoc working with Gus and me, and a medical student, and then some of our undergraduate and graduate colleagues. And they developed an automated objective method for comparing point by point this to this, doing ROC curves, doing sensitivity, specificity, all automated, all objective, right? And the short version is, you can read this article yourself, the short version is local structure and function damage agree even in eyes with early glaucoma. And in fact, going back to that prospective group of 53 eyes, 80, close to, let's call it 90%, close to 90% of the eyes show agreement, whereas if you use the standard metric and you only use the 24-2, you would get only 62%. So the metric's not a good measure, topographical measure is good, it can be done objective. So in general, local structure and function agree even in eyes with early glaucoma. So, and this is worth repeating, but you're only going to get good agreement if you use 10-2s and 24-2s, or the functional equivalent, and if you use both probability maps, and if you compare local regions, right? So you've all seen curves like this. These curves drive Ted and myself crazy because everyone shows this without thinking about it, and it's here to make the point that, oh, well, first you see change on OCT, then you see change in the visual field. Just not true. In general, they go together if you look at local probability maps. Right? Take a look at this. But you can also take a look at some of our older work. You know, so Ted's been saying something equivalent to this since 2004. And there's a number of publications that he's been involved with, and Bill Swanson, and then our group. Now you might say, well, wait a minute, what about the histology? You know, don't we know that you need to lose 25% of your ganglion cells before visual loss? Not true. In fact, it was never true. And again, I refer to these articles from us and from Bill and Ted. The histological data do not support that conclusion that everyone's making. I recently revisited this. This is a recent J glaucoma perspective that summarizes some of the arguments that we have made previously, and Bill and Ted have made, and added a few new arguments. And we come out with, if anything, the classic papers argue the opposite, that the sensitivity loss in the visual fields can be seen in some cases before ganglion cells are lost. All right, the final point is you want to inspect the scan image, and I'll give you I'll give you one reason. I'll give you one reason now, and if there's time at the end of the second talk, I'll mention briefly 5 more reasons. You can't trust segmentation algorithms. All algorithms make mistakes. In some cases, it's because the scan quality doesn't allow accurate segmentation of the individual layers. In some cases, it's the tissue in the vessels isn't always accurately incorporated. Epiretinal membranes wreak havoc. Vitreal separations do too. So you want to carefully examine this before you start believing your maps. And here's some old studies that made the same point. All right, so that's the first part of this talk, Anthony. In the second part, I'll talk about where you can find these reports on your instrument.
That's fantastic. Thanks very much, Don. So maybe if you stop sharing, then it will bring up all of the panelists who can now unmute if they want to join in. That was really, really clear and so many important clinical messages. Thank you. There was one question that's come in through the Q&A. Other participants, please do put in your questions. Was the macular involvement, I think this is when you were looking at early glaucoma, more common in older people? And what about younger patients? Do you see as much early macular involvement in younger patients?
No, that's a good question. I don't think the age is the right variable. To the extent that you think normal tension is more common in some age group versus another, then we know the local damage is it's not complete by any means, but we know it's more common in so-called normal tension glaucoma. But I don't know of anybody who would hold everything else constant and then ask whether it is more common. So I think you want to ask what's the type of, is it normal tension, is it secondary glaucoma?
Something related with that question that's probably important to address is other confounders of macular damage, non-glaucomatous, which are more commonly found in older subjects. And that goes back to Don's point on looking at the scans. I believe in the second part of your talk or before, you're going to mention some other retinal pathologies that can often mimic, and you see the structure and function agreeing pretty well. But because they agree doesn't mean it's glaucoma. Especially in older.
The two most common mistakes we find when we're giving secondary opinions is missing ION, confusing ION, and superior and especially superior segmental hyperplasia. They're both often misdiagnosed as glaucoma.
Sorry, Don, I couldn't quite hear those clearly. Or maybe I just never heard of them.
No, ischemic optic neuropathy.
Okay.
And superior segmental hyperplasia. Congenital hyperplasia.
Congenital
superior segment, yeah.
Okay.
There are patients out there being treated for glaucoma who have congenital thinning.
Yeah.
You know, Don, the statement "don't use metrics," well, I'm assuming is meant to be provocative. You know, you use metrics. I think the warning is against global averages and global metrics that, you know, by design, smooth data, but also mean that you change your sensitivity. So you know, you're using metrics. Of course, your maps are based on metrics. So I've always.
Yeah, fair enough. Yeah. Let me be very specific. When it comes to comparing structure and function, or when it comes to defining glaucoma, like it's being done at the moment by Harry and colleagues, right? Then metrics, by metrics, I mean mean deviation, pattern standard deviation, and glaucoma hemifield. So I mean those three measures when I see metrics, and I mean for the purpose of structure, function, or definition.
Right. Global, large, you know, they consume a large amount of data into a single metric.
Right.
And
Absolutely.
Ted.
Great. So once again, Don, thanks very much. That was super clear and really underlining the importance of a systematic approach to putting the structure and function data together to properly interpret the information that's in the tests. My question is, a practical one. So you started off by saying, well, in anyone who you've got a reason to do a visual field in, you should do a 10-2 as well. And that has huge resource implications because you're doubling the test time. And we simply, particularly in these days, post-COVID, or still during COVID, we don't have the capacity to invest in that. So I wondered if there's a way you could maybe refine that advice and give some guidance as to which patients we should really be doing these 10-2 tests in.
Yes,
and
so
yeah.
So let me tell you what our standard answer is, and then we're going to pick this up again at the end of the next talk. So you want to come back to this. But if you're a traditionalist and you insist on your 24-2, right, then anything at all should buy somebody a 10-2. A vague complaint, one spot on the 24-2, any vague complaint about contrast or problems with light levels. What I'll argue at the end of the second talk, however, is if you do an OCT first, then you can decide which patient you want.
Okay, yeah, absolutely. Great.
By the way, just while I have you on the screen here, you probably don't remember it, but one of the first times we met together, sitting at one of the meetings, you said, "Why do people still say structure comes before function?"
Yeah, I remember well.
They still are.
Yeah.
So Pagnotta, then Jeff.
Thank you for a great talk. I was wondering whether you could comment a little bit on the new paper, probably you've read it, by Harry Quigley's group on the new standardized definition of glaucoma using visual field in OCT. Now, I understand that this is for research purposes, not necessarily for clinical practice, but still it does rely on RNFL segmentation of the OCT, which you did show that it has flaws, and also it doesn't take into account at all the macula. So, so do you think that it would still be good enough for research purposes, or do we need to look into more elaborate definitions?
Yes, so what I'm about to say to you is been public knowledge among a lot of people in terms of the exchange Harry and I have had on the internet, and something I would say to Harry too. It is grossly inadequate. It is misguided. It is a mistake. You are ossifying a definition of glaucoma using 20th century techniques when we now have 21st century techniques for all the reasons I gave. Gus has his first author on a nice paper that talks about staging glaucoma based on the different staging techniques. All of the standard staging techniques, including the one that he's doing here, miss early glaucoma. I think you would agree that the patient I showed you with the ocular near fixation shouldn't be just early glaucoma, or shouldn't be missed in definition of glaucoma. What Harry's doing is just wrong.
Thank you.
Thanks. Jeff?
So just to come back to Ted's point about clinical care, when we think about visual field testing, we follow patients over many years, of course. And I think every patient somewhere along the course of care needs a 10-2. Whether we have 5 or 6 24-2s and one 10-2 or not is not going to really affect the long-term ability to detect progression. It either provides a baseline for future comparison of 10-2s or detection of early damage that's paracentral, which is critically important. So somewhere along the way, I think everybody probably needs one. The other issue that Don alluded to was structure function assessment, but really we're doing structure assessment for early diagnosis. In the past, we never could look at macular damage clinically. So if we have someone who has a suspicious nerve fiber layer defect on OCT, sometimes it's a myope, we're not really sure what's happening to the patient. Look at the macula, we see corresponding defect at that location. It really reinforces to us that this is a ganglion cell injury with corresponding axonal injury, and is likely glaucomatous in nature. And in the COVID era, when we're relying more on OCTs, I think that this is going to really accelerate the use of this technology platform the way Don described it. Thanks.
Great point. And just to play devil's advocate, I'll return to the first point again. And whereas I do broadly agree with what you say, when we're following patients over time, we're trying to generate sufficient visual fields to get a trend over time. As we all know, that's a very noisy series of data. And if we take time out and drop a 24-2 field to do a 10 instead, then we've lost an opportunity to add to our data set for progression. You know, as I say, playing devil's advocate, in the past we've sort of advocated not doing swapping backwards and forwards between different types of tests, because then you don't have enough data for your trend analyses.
Well, absolutely. That's an excellent point, because in the days when we had polarimetry and HRT and OCT, you know, we get a hodgepodge of data and not have enough information. And so I think that's a critical point for the audience, that you need enough valuable and analyzable data on one particular test to make decisions sometimes, and that's a very good point.
I'm glad that's come up.
Can I just add 2 points about that just quickly? First of all, nothing stops you from deciding a 10-2 is right and then following a patient with 10-2, right? But secondly, I think the other thing that needs rediscussing, and I just submitted a review on this that Jeff is aware of. The whole glaucoma progression analysis needs reanalysis. You folks don't want to know whether there's been progression over 4 days. You want to know whether there was a progression since the last time. And I think with OCT and field combinations, there's an opportunity to do that. So I think you're embedded in an old way of thinking about this, where you need all these visual fields to make an analysis of progression. I think that's going to change.
I think that's a great point. I mean, we don't yet have the clinical tools to quantitatively put together our structure and function yet, but I agree absolutely that's the direction we're heading. 100%.
We can come back to this after the next part.
Okay. Just a couple questions from the participants. Could you please expand on the inferior vulnerability zone? Why infratemporal and not supratemporal, for example? Great talk, by the way. Thank you.
Yeah, I wasn't around when we evolved, so I'm making a guess here. I think it has to do with the offset between the foveal center and the disc, so that part of the macula actually doesn't go to the temporal region. The inferior part of the macula goes to the inferior vulnerability zone, it goes to the inferior quadrant, where the superior part of the macula goes to the temporal quadrant. And that's because of the offset, I think, between the center of the fovea and the center of the disc.
Okay. So you're not exactly sure why, but it is definitely the case. That bit is more vulnerable. And one last question, I think, before we move back to your talk. What about patients with high myopia? It's very tricky to separate high myopia visual field loss versus high myopia glaucoma.
That's a great segue, because if I have enough time, I'm going to show you a slide about high myopia.
Okay, so do you want to share your screen again, and we'll move on to part 2? I could ask all participants to go on mute if you haven't already. Thanks.
Can you see this?
It's not full screen yet. And now it is. Thanks very much, John.
All right, so this is where we left off. So let's return to this report. By the way, a comment I was going to make that reinforced Jeff's point. One of the advantages of this report is you're getting different measures of structure that you can compare. You know, so that's so the embedded in this report is a structure comparison. So if you have a TopCon machine, TopCon now has, so the topic is, where is it on my machine? So the TopCon now has a 3D wide glaucoma report, and we work with TopCon, so there's the financial disclosure. I don't get money if you use this, but we do have grants and equipment. And this is based directly on our lab report. And it's been validated with this study here. It uses a single scan. It uses their 12 by 9 millimeter scan that's available on both the Maestro and the Triton. And this report right now is available, I think, around the world on the Maestro, including the US, and also the Triton, except in the US. More recently, Heidelberg has come out with what they call a hood glaucoma report, which again is based, we work with Heidelberg, so there's the financial disclosure. The Right now on Spectralis, you can get this report, which is like our report, except that it does, this is thickness map here, flipped into field view, and then they're trying to get approval to actually have the probability map. So that's what we would recommend on those two machines. I know in the clinic you have a Cirrus, I believe, that a lot of the patients are tested on. This is the report that everyone's been using for years. It's still a useful report. However, it does not deal with the macula. So you want to make sure you do a cube scan of the macula too. And here's the equivalent report. You know, this is a thickness map. This is a probability map that I'll say more about at the moment. My favorite Zeiss report, and the one that Gus and I recommend, is the Panomap, because it's got some similarities to our report. I think that's why we like it. And so let me just say a little bit about the Panomap, because I highly recommend, if you're going to use a Zeiss machine, look at the Panomap. So the Panomap is based upon the two cube scans, one centered on the disc, one centered on the macula. This is a thickness plot, very similar to our thickness plot, based on those two scans. The probability map, which they call the deviation map, is different in a couple of ways. The most important way is they do the probability map for the retinal nerve fiber layer, and then this is the probability map for the ganglion cell. So they're combining retinal nerve fiber layer and ganglion cell. We keep them separate. This has some advantages, but it's got some disadvantages too. We can discuss if you're interested. This is your usual circumpacular retinal nerve fiber layer thickness plot that's derived from a derived circle scan. I find this totally useless. I totally ignore that. I would recommend instead they show you an image. It doesn't have to be that big, but it should be big. And there are things they can do to make that a little prettier, by the way. All right, so what should you use if you have a Zeiss machine? You should use these two for sure. It doesn't hurt to also look at this, because sometimes there's information here in the thickness map, which you don't have here unless you actually click on this and change the setting. And of course, look at the image. We could send you a screen capture of this. This is the overlay of, on average, of what 10-2 and 24-2 would look like. And once you see this, you don't need to actually have it on physically, I guess. You can sort of picture where it is. All right, now, so we talked a little bit about this. The power of a report, something like this, is if you get most of the information you need in one place, you are going to be more accurate. And as Gus always reminds me to tell clinicians, you not only will be more accurate, but you'll be faster, right? Because everything should agree. So instead of multiple tests, as Jeff was pointing out, you have multiple comparisons here that in some ways are quasi-independent. So my eye is brought to this immediately. That's bad. That's right near fixation, and it looks like it's an arcuate defect. Is that optic neuropathy? Well, if it is, then the retinal nerve fiber layer by the disc should be thinned. It is. And there it is. It should show up here, right? And on the thickness plot, maybe it does. On this, and also there it is on the image. You're done. You're done in 5 seconds. That's not always that easy, of course. If everything's normal, you're also done in 5 seconds. And you can spend your time on the eyes that don't fall into those categories. When I say everything should agree, if you think you need confirmation, now this is certainly an eye that you'd want a 10-2, but this eye has, that's the 24-2 for this eye. Now that's a little confusing, you know. If you just had that by itself, is that retinal, is that glaucoma? Well, once you have this, that's the point. So it's to be expected, and there it is there too, right? If you do a 10-2 now, and you can then see the agreement. All right, so under the category of what's going to be new, I'll say more at the end of the talk about this, but here's a perspective that was just published in the Journal of Glaucoma, or it's about to come out. And what we did is we took our prototype of the report for two instruments we work with. And we, in this particular patient, by the way, looks like an extended nasal step here. You can see there's probably an arcuate here. So we wanted a way for initially to teach the clinician and help the clinician look at the relationship among different regions on this report. And ultimately, this would be turned into something that could be quantitative. Right? And then what we hit upon was the clinician will mark the region that they're interested in here. They can move this around, make it different widths. And then up here will pop the predictions based on a modified Jansonius model, so that you can see the relationship, at least qualitatively, between structural damage in one place and structural damage in another place. And then here's the same thing for the Spectalis report. Again, these are our versions of these reports that we're now playing with, but we're working with both companies so that eventually this will get into the machines. Okay, so as I said before, these recommendations that Gus and I made years ago were led to some suggestions, but I think it's time, or we think it's time, to rethink it. So now I'm going to bring this up to date in terms of a clinical recommendation. And so here I want you to hold off for a moment. You're concerned about multiple tests, you're concerned about billing, you're concerned about workflow and when somebody's dilated, and just think about the logic here first. So the suggestion is, the first thing you do is get an OCT, right? You always look at this image, right, to make sure you've got a decent image. And you look at this report, and based on the report, you decide, do I need a visual field? And if I need a visual field, is it a 24-2 or a 10-2? In this case, I think you'd agree you would get a 10-2. At that point, you can ask whether it agrees with these probability maps. Another example. That looks like an arcuate defect near fixation again. Here it is here. Yeah, it's not as impressive as I would have hoped, but something's going on there. There it is. But that doesn't look right to me. That's just too deep, too local for me to feel comfortable calling this an optic neuropathy. So 10-2 confirms it, by the way, and confirms that it's really deep. So this is really worrying me now, because that's too deep and too local to be glaucoma, right? Sometimes you have to go to the machine and look at the B scan. If you look at a B scan through there, you'll see, this is not the fovea, the fovea is up here. You'll see there's a lesion here that goes right through the eye. So, as Gus pointed out before, a second reason for looking at B scans is you want to identify masqueraders and identify outer retinal damage. Now you're thinking, oh no, I have to go to the machine? All right, we'll talk about that in a moment. Here's another example. Oh, your faces are blocking this. Okay, here's another example. Obviously segmentation problem there. What's going on here? Is this an artifact, right? Well, no, you do a 24-2 in this case because you want to confirm this, and look at this, you have a hemifield defect. So what is this, right? You look up here, this is not an optic neuropathy, because if that hemifield defect was real, all of this should be down, and this should be down here. So this is not internally consistent with an optic neuropathy. So again, sometimes you have to go to the machine and look at the image. If you look at the image, you can see that this is vascular. The internucleal layer is gone here. This is branch retinal artery occlusion. One last example. You'll often get bad images, and I'll tell you why this image is so bad in a moment. But you can see you can't trust the segmentation there. And there it is. Anytime this goes to 0, you know you have a mistake. Right? But look at this. See all this on the en face image? See all this? See this? That screams epiretinal membrane. You don't even have to go to the machine. If you want to see how bad the epiretinal membrane is and whether you want to refer this patient to a neuro-ophthalmologist, well, you go and look at a B-scan again, and here's the epiretinal membrane. Or you can look over here, here's the epiretinal membrane. So sometimes you have to look at the B-scan. I haven't said much about progression, but the same logic applies to progression. So here's a paper by Wu et al. When Z Wu was a postdoc in our lab. And if you can line these up between days, you can flicker them the same way you used to flicker, some of the old timers used to flicker photos. And the logic we're using with glaucoma is the same logic we're using for detection. Everything should agree. So if this is getting worse here, then that should be getting worse, right? And this should be getting worse. And you should see it in the image, and you see it here. Now this is 1 year apart, you know? I don't think you need visual fields to confirm progression in this particular eye. All right, so what's new? Here's something new from TopCon based on our work, and it's now available in Canada and at least the Spanish-speaking parts of South and Central America. And what it is they've broken up our report into pieces and made it interactive. All right, so now, true, you have to go to the computer, but the young folks in this will appreciate the fact that they're always going to be going to the computer in the future. You go to the computer and you have everything there you need. So if you switch this toggle from here to here, this goes from a 24-2 to a 10-2. If you switch this, it goes from a total deviation to a pattern deviation, right? This is available right now. In terms of progression, again, assuming it was lined up well, you hit this little button here and you can flick it between 2 days. So if you have a long series, Ted, you can go back and look at the first versus the last, but you can look at the last one versus the current. And here is a report also that's available that shows the 2 days. So this is what, between January 17th and November 18th, you can see that taking this all together, you've got progression. You can also compare it to the visual field, you compare it to the thickness plot. And this is with the 10-2, that's with the 24-2. All right, and here perhaps is my favorite part. You can click on some of these and make them interactive. So let's suppose you were worried about what's going on here and here. You click on this, you can now scroll up and down and take a look at the B-scan, and you can see that in this case, the B-scan, as you might suspect, was ignoring a retinal nerve fiber layer and attributing it to the retinal ganglion cell layer. So that's an illustration of something that's available now, and it's clearly the direction we're going to be going in. You're not going to have printed reports. You're going to be sitting at a console and being able to interact with it. So I promised, do I have a couple minutes here, Anthony?
Yes, definitely. Please
okay.
Carry on.
So I promised that there were 6 reasons. I've given you 2 so far. Let me just briefly mention these. So somebody, so number 3, we, for at least 4 or 5 years now, we have been following patients with advanced glaucoma, including eyes with global thickness of 29, 30, clearly below the level where the conventional wisdom is you can't use the OCT, right? Here's the rule that we tested in this paper. If you've got a point or 2 on the 24-2 or 10-2 better than -8, it's almost guaranteed you will have some tissue remaining someplace on your circle scan if you get a high quality circle scan. So we follow clinically advanced glaucoma by looking at quality circle scans. So you can look at this and you can relate it back to the visual field by knowing the topographical agreement. So this is what we're following in advanced glaucoma. Same thing with high myopia. The current wisdom is you can't use it for high myopia because the metrics can't be used because they depend upon eyes that are plus or minus 6 diopters. Well, it turns out, again, if you have a decent quality circle scan, you know, this eye here is minus 13.5, but you can follow that over time. First of all, you can diagnose it. It's clearly up or up. Same thing with understanding progression, whether it's in an eye with or without high myopia. You know, what we routinely do is look at the change in the tissue the same way a radiologist would look at a change in an MRI or a CAT scan. This is an aside, but it speaks to the issue of using global statistics or quadrant statistics. We've got 3 papers under review that make different versions of the same point. And that is, if you think you can use global thickness or quadrant thickness, the answer is, please look at the image. First of all, it's probably going to cure you and you won't be looking at it, but at least you'll know whether you can believe it or not. And here's why. First of all, local defects like this right here, which is clearly present and progressing, that contributes about 2 microns to your global thickness, right? Here's a subtle segmentation error, right? Very subtle segmentation error. That contributes about 2 microns. So unless you can be sure you don't have segmentation errors, you've included all kinds of noise in your global and quadrant analysis. All right, last point, and in some ways this is one of the more important ones. All of these defects here, right, really are due to damage in about a 45 to 90 degree part of the disc, mainly about 45 degrees. All damage here is giving you all of these changes within that blue region, right? And what this means is, if you look at this, you will see a very wide range of different kinds of damage. And so it shouldn't surprise you that you get a wide range of visual fields. I think eventually we're going to be looking at this carefully and understanding the nature of glaucoma and its damage and how it relates to behavior, the same way a neurologist would look at an MRI or a CAT scan. And this is developed and explained in this review up. So that's an update of where we are. Some of this material can be found in this site here on the website. I might also put, I think I may re-record this lecture and put the lecture on the website too. Thank you.
Brilliant. Thanks so much, Don. Really, really clear, lots and lots of pearls, and I'm sure. Yeah, so yeah, if you stop sharing, then we can move to the panel discussion. Hopefully people noted your website. Maybe I could take the first question then. So when I first started incorporating doing the macular scans in my practice, you know, one of the things I noticed is quite a lot of patients who we were following as ocular hypertension, we thought they were fine, had some very clear, you know, classic loss in the ganglion cell in the plexiform layer, which had been missed up to that point. But then for lots of my patients as well, I find, like, you know, I can see areas where I think maybe there's been some thinning, and then the next time it's thickened, and then the next time, and I feel as though I'm not getting consistency across time. I seem to get that really nicely for younger patients, but for our older patients, which is a lot of them, there seems to be this inconsistency. A lot of patients have epiretinal membrane. I'm just wondering, in the real world, how many, what proportion of your patients can you do this kind of, you know, beautiful analysis which you've just shown us, probably on people that have got clear media and somehow managed to get really repeatable tests on them.
Mm-hmm. No, fair enough. I mean, so the patients we see, at least from one clinician we work with, are often really tough cases. High myopia, advanced glaucoma. And I can't give you a percentage, but certainly a fair number of those, if you just look at the report, it's not going to be enough. But we can usually come to an answer if we have a decent circle scan that we can go back and look at, and if we go to the machine and look at line scans. As the information's there. But if you're going to just try to to follow it based on global statistics, forget it. You know, I mean, and that's the point of these recent papers. You know, the epiretinal membrane, you know, can easily contribute 15 microns to your global statistics. So if they're using a rule of 5, forget it. I mean, anybody who still believes in the rule of 5, and now I know there's some articles against it, anyone who had looked carefully at the segmentation and calculated what the segmentation errors do would never have used the rule of 5 in the first place.
So I would add to what Don says clinically. I believe the majority of patients, I don't know exactly the number, you just look and see everything matches in terms of everything being normal topographically, or everything matches being abnormal. You see a fair number of those cases. And I agree, there's some cases that you're not going to get that straightforward. And my impression is that those are probably not patients that you need to have a decision at that moment. You could probably have them come back, repeat to another visual field. It's not always that you need to start treatment at that point, or you need to make a decision about progression. So often you have time to repeat and do that, which we've been doing for quite some time in glaucoma repeating tests.
Yeah, no, I frequently do that.
Yeah, there was something else about it. Just a minute, Jeff. I just wanted to, before I lose the thought about Anthony's question. One of the toughest things to diagnose, and this is not because of bad exams, is subtle diffuse damage of the macula. You know, so for me to feel really comfortable with diffuse damage, I need to see it on the ganglion cell plot, a circumpapillary plot, and then 10-2. Because, you know, or at least 2 of those I need to see. Or if I have complaints, any 2 of those 4 you need.
So let's also remember that we should be looking at the retina. So, you know, you examine the retina, and we find a lot of pathology that helps explain the aberrant images or unusual cases. So we're still ophthalmologists, we still want to look at the eye, even though none of us wants to get that close to the patients at this moment, address the disease. But
well, we routinely look at a line scan through the fovea.
I'm talking about looking at the eye.
No, I understand that. I'm saying that. I'm saying that some of what you want to do in terms of picking up other problems in the retina,
right,
to do with the OCT.
Yeah, so between what you described here today, Don, and the clinical exam, really we get down to very few patients where we can't explain the pathology in the retina on the OCT. So.
Ted?
Yeah, I was going to start just with a comment, just to make the point that so often great research stays in the lab, and there's a translation gap getting it into the clinic. And Don, you've done a fantastic job taking the manufacturers along with you to produce all these tools through in the software that we can use in clinic. And I suppose the question related to that is that as the tools develop, there'll be more and more of them, that you can dig really deep into the data and look at the images in great detail and do a lot of thinking, and that's going to take more and more time. And the question is, you know, how do we make up that time? And, you know, one of the ways is by not having the patient in front of you. And we're doing that increasingly in our clinics, and doing remote clinics where patients come in, have all their tests, go away, and then we can sit in the comfort of our own home looking at the data and thinking about it. And we've had a sort of local debate about whether or not we need photographs as well, which speaks to Jeff's point. But do you foresee a day when the number of encounters between the physician and the clinician is diminished considerably? It'll never go away, but do you think we'll be doing a lot of this remotely just with the data that we get?
Yeah, I'm not sure I'm qualified to answer that question, but I think the easy answer is yes, of course, it's going to be fewer. The question is how many fewer. That's really what you're asking. I mean, you're doing a lot of it remote. If I remember correctly, you do a lot of decision making remotely even before the virus.
Well, that's right. It was, I think, 20-25% or something like that. And
so if you're comfortable 25%, I suspect that could be substantially improved with better technology.
Absolutely, yeah.
Anthony, can I say a word?
Keith, yes, please.
Don, this is fantastic, but as Anthony has alluded, you know, where do we see this in the clinic? And he's pointed out where patients, you know, with ocular hypertension, might actually have glaucoma and maybe need treatment, you may miss. But still, the clinical significance here, or the clinical need, is in people with much more severe glaucoma. Whereas if you miss something, they're actually going to go blind. Whereas here, if you miss something, you're talking about a little bit of change. You're not really talking about severely impacting my practice, which is a lot of people with really bad glaucoma, and you're really trying to pick up any slow change over time because it may be vision threatening. This ultimately, most of what you've shown, not all, but most of what you've shown is not vision threatening. It's very early change. You miss a bit of it, it doesn't make that much difference. How do you see this research moving on to relate to people who really are serious risk of blindness?
Yeah. So let me just deal with the premise first, and then I'll answer your direct question. Dana Blumberg at Columbia, along with Jeff and others, has been looking at following up on our observations about this early diffuse damage. These people with early diffuse damage, which is relatively subtle to pick up, in fact, have a change in quality of life. They have a change in face perception, right? And
I get all that. I fully appreciate that. But the patients don't come in and tell you that. That's still stuff you're detecting under research circumstances. Right. And if you try and convince a patient that they need, the quality of life change that they get is putting in an extra medication that they hate. Right. You know, that's actually makes more of a quality of life change than actually what you're detecting.
Okay, so let me answer your question directly. So the most direct contribution we've made so far is our ability to follow advanced glaucoma. Now,
yeah.
And again, I want to be very careful. If you have anything left on the visual field that's better than -10, -8, right?
Yeah.
There is tissue you can follow very carefully, the same way you would follow a tumor in my brain.
Better than -10, did you say?
Better than -10.
Yeah, but that's a...
All right, yeah. So
honest, there aren't that many of these patients who are better than -10.
No. I'm talking about 1 point. 1 point on the field.
Okay.
Most of these patients are -30.
Yeah. Okay.
Most of our advanced patients that I'm talking about are -25, or worse, right? Those patients that are -25 or worse, the ones that you're still following with a 10-2, right? Yeah. They can be followed easily with the right OCT scan if you get a good circle scan.
Because honestly, this is what we need, and I fear that there's so much focus on mild glaucoma, which is of course important, and I get exactly what you mean. And if you improve the average for everyone, then maybe fewer people will end up with advanced glaucoma. But in the clinical scenario, I've got these elderly people with really advanced glaucoma. I don't know if they're getting worse or not, except I just got to keep doing more and more visual fields.
Well, no, but again, before I would worry about doing more and more visual fields, I'd get a good circle scan on them, and I would look for the tissue that's remaining, and we follow that tissue routinely in eyes with mean deviations in 24-2 that are gone. Nothing on the visual field. But they have to have a little something on the 10-2. You know, I want to be very clear. A little something, it could be 2 points that are better than -8. And so I had that one slide, we can put it back up again if you want, that you'll often see a little tissue left, but you have to get a good circle scan. You've got to get a good circle scan.
I guess I asked the question, which you've probably been asked before. I know what the answer is, but the insurance company only allows you to do one test a year, which isn't appropriate, of course, in this sort of patient, but sometimes what happens, what do you choose, the 10-2 or the OCT?
Well, I'll tell you very clearly, if this were my eye or one of my older relatives, which I don't have too many of those any longer, I would first, if that high resolution circle scan, like say that you can get, if that had some tissue remaining on it, and it's in the region associated with the macula, I'd want you to follow that.
Yeah.
Because that's what I want to keep. The same way you would follow a tumor in my brain, right? You wouldn't take my brain and put it through an algorithm and ask whether it was red or green on some kind of a map.
It's slightly different, but yeah.
No,
I'm bringing this up not to play devil's advocate, really, but to just plead the cause for the people with more advanced glaucoma that seem to be peripheralized in research.
Yeah. Well, so send me your email and I'll send you 2 papers. One's published and one's under review, both on advanced glaucoma, both using circumpapillary OCT to follow.
Thanks.
One's detection, one's progression.
Thanks very much, Don. I actually wonder whether moving now, as we come back to our practices after COVID, we will see what the impact is of seeing some of those patients that were originally maybe early, having not had intensive follow-up or potentially treatment. And I wonder whether we will see some people who've lost considerable vision. Because at the moment, I guess there's only very small studies we can look at that have natural history arms. What would happen to these people if we weren't intervening? Any other questions before we move to our last talk? Jonathan.
Can I follow on from Keith? And we get a lot of patients referred to us from the community with abnormal visual fields that prove not to be reproducible. And there's quite a lot of skepticism in my mind about the benefit of performing field tests in the community. And I just wonder, could this technology replace the requirement for visual fields, or are we just going to generate a whole load more false positives?
Yeah, this is something that Jeff Liebman's been asking me about for years, and Jack too. Again, it's going to be similar to the question, the answer to Ted's. The answer is absolutely yes, but the extent to what, the question is to what degree. So can this lead to fewer visual fields? Yes. And so the question is, do we ever get to the point where we need, how few can we get to? But we certainly can get to fewer than we're doing at the moment. And my bet is we can do that without sacrificing sensitivity and specificity.
Okay. Well, great discussion. Again, Don, thanks very much indeed. I don't know if you're able to stay for our clinical case.
Yes, sure.
Okay, brilliant. Thanks. So